In many ways, diagnosing parasitic infections can actually be relatively easy. Hey, the person's got a worm in their gut. Like, that's not that hard to figure out. But the reason that it becomes tricky is, especially for physicians who don't commonly see parasitic infections, they might see symptoms like diarrhea and not necessarily go to a parasite. They might think maybe bacterial or viral infection instead. Treatment, however, of parasitic infections is very complicated. So for diagnostics, a lot of these things you can see with your eyeballs. If a patient has tapeworm, you can probably see the sections that we call proglottids in the feces. If you've ever had a pet, like if you've ever adopted I have two cats that were adopted as kittens that were found outside. They had tapeworm when we first adopted them, and you can see the little grains of rice in the poop with just your eyeballs. You can do microscopic examination, especially of blood or feces, looking for eukaryotic organisms. Sometimes serology works, nucleic acid testing. Culture is not terribly common, but can be done for some of the unicellular parasitic organisms, and using animal inoculation. In order to diagnose parasitic infections, it can be really important to understand the life cycle of the organism. I highly recommend, if ever you're able, that you take a course in parasitology, just like a straight up semester-long course in parasites, because there are so many and their life cycles can be so complex that this course, we really don't do them justice. So if you're ever able to, I recommend it. But in terms of like understanding life cycle, sometimes organisms are at higher numbers in the bloodstream at night. So if you take a blood sample during the day, it may be hard to find the organism. You actually need to do it at night. Sometimes eggs of the parasite might be found in the lumen of the intestine versus in the wall of the bowel. So you need to know where these organisms might be found. And sometimes patients will experience symptoms, but you may not be able to diagnose the infection yet. Perhaps the parasite load isn't high enough to diagnose. The parasite hasn't gotten to the right tissue yet that makes it easier to diagnose. So even though these are generally relatively large organisms that sometimes you can even see with your eyes without a microscope, it can be challenging to diagnose these infections. For the most part, when we are diagnosing parasitic infections, we're using microscopy, unless it's one of the worms. But even then, to determine perhaps the species of worm, it can be really important to do microscopy. There are some parasites, just like every other type of infection, that can be diagnosed using things like antigen detection or serology or PCR. And there's a table in the text, in the newest edition of the text, it's table 70-1, gives tons of different organisms and how they can be diagnosed. In the US, intestinal parasites are generally the most common. We don't tend to see like the ones that burrow into your eyeballs, but they exist too. The most common is Giardia. So what we're looking at in this chart is, approximately 3,000 patients who are positive for a parasitic infection, gastrointestinal parasitic infection, and which is most common. So most common is Giardia. Next is Dientamoeba, again, gastrointestinal. All the way down here, Ascaris. This is a roundworm. So these, Cryptosporidium, Entamoeba, these are all unicellular organisms. But then down here we have some of our helminths. This one right here is a pinworm. And then Even more rare are going to be things like tapeworm and some of the other helminths. But again, we do see parasitic infections in the US, some that are acquired in the US, and some that might have been acquired abroad if a person was traveling or has recently moved to the United States. So it can be important for you to be able to recognize these things. When we're talking about trying to diagnose, especially intestinal parasites, it can be important to collect multiple samples. And the recommendation is that if you are collecting fecal or stool samples from a patient who you suspect has a parasitic infection, you should, over a 10-week period, have the patient provide at least 3 samples, but not from the same day and not from consecutive days. And so what we see in this table here is there were 130 patients who had a parasitic intestinal infection. If they provided 1 stool sample, about 71% of them were diagnosed as having the infection. If they provided a second stool sample, that number jumped up to almost 87%. And with a third stool sample, all of the patients were able to be diagnosed as having an infection. So it's not always a one and done. It's great if you see something on the first sample, but if on the first sample you don't, collect a couple more. For potential GI pathogens, stool can be directly examined. If a patient has something like a tapeworm or a roundworm, you can usually see the organism itself in the feces. For some of the unicellular organisms, you could do a wet mount or microscopy. So things like Giardia, you'll want to use a microscope and you can see them there. If perhaps the patient has a gastrointestinal infection, but you may suspect that there are only small numbers of organisms, you can try to concentrate the stool sample to hopefully see them in there. Other mechanisms for collecting either GI or even urogenital samples for patients that you suspect, especially for patients that you suspect have pinworm, you actually have to collect a sample right around the anus. And the way that this is commonly done is using tape. You put a piece of tape and the pinworms come out at night to lay their eggs. And so they'll get stuck on the tape when they come out at night to lay their eggs. You can do an intestinal aspirate or scraping of the mucus. If you suspect liver involvement, if the patient has a liver abscess, you'd want to do a biopsy. Sputum, urine collection. There are a couple that will go to the genital tract, so you can do a wet mount of the genital tract. So there are a number of different collection mechanisms. For blood, a wet mount of the blood, if you think that the parasite might be mobile. You can do thin blood smears, which are 1 cell thick, especially if you have high parasite density. But if you have a lower parasite density, you might have to do what's called a thick blood smear. That allows you to see larger volumes, but sometimes it can be distorted when you're looking at it under the scope. If you suspect a patient has Naegleria fowleri, you would do a spinal tap and you would see the parasite in the cerebrospinal fluid. This is sometimes called the brain-eating amoeba. And you can do tissue biopsies for potential intracellular pathogens like leishmaniasis. Other diagnostic techniques, again, serology, detection of parasite antigens, nucleic acid detection. You can culture for certain protozoans, or you could take a patient specimen and inject it into an animal to see if the animal develops the parasitic infection. Now, treating a parasitic infection is difficult. Let's think about why. Treating bacterial infections tends to be easiest because bacteria are so different from us, the host. Viral infections are difficult to treat because viruses take over the host cell. So if you're treating a virus, oftentimes you're treating and killing the host cell. So it's a little bit trickier. You have to identify features of a virus that are different. So for example, reverse transcriptase that's found in hepatitis B and our retroviruses, or neuraminidase, which allows the flu virus to escape host cells, can be treated with something like Tamiflu. So if they have a unique target, you can go for that. Fungi are difficult to treat because they are eukaryotes, just like the host cell. So again, you try to identify novel targets. Maybe we can target their cell wall, because we don't have a cell wall. Maybe we can target the cell membrane, because the cell membrane has that ergosterol, and our cell membrane has cholesterol. So hopefully we kill the fungus before we kill ourselves. When we start talking about parasites, it's again complex. They are eukaryotic organisms, and many of the treatments that are identified to treat parasitic infections also target the host, because we have very similar pathways. Here, there are listed some pathways that can be targeted and why they work. For example, chloroquine, Plasmodium has a very unique mechanism where they actually will concentrate the drug, and that can kill them. You can inhibit the folic acid biosynthetic pathway. This actually also works against bacteria. Many bacteria and also many parasites are unable to use exogenous folic acid. They have to make their own. They can't import it and use it. So if you block their mechanism to make folic acid, they'll die. So trimethoprim sulfamethoxyl is also a drug used to treat bacterial infections. Again, there are a number of other mechanisms here. Interaction with tubulin that's unique to parasites, inhibition of a particular topoisomerase, interacting with chloride channels, resulting in hyperpolarization and death of the parasite. So it can be tricky, but you'll see we don't have a ton of different drugs here to treat parasitic infections. What we're also starting to see, just like with everything else, is that there can be resistance now in some of these organisms to some of these drugs. They have mutations that have altered the drug binding site, they've upregulated some of their efflux pumps, and we're even seeing parasites that are becoming multi-drug resistant. What antiprotozoals tend to do, so these are our unicellular eukaryotic parasites. The drugs that target them often target rapidly dividing cells. So we also have cells in our body that divide, and some of them divide rapidly, so we can have some cytotoxicity there. There are heavy metals that inhibit carbohydrate processing. Well, heavy metals hurt us too. So again, it's that challenge of, can we kill the parasite before we kill ourselves? The quinolones that are used to treat quinolins, not quinolones. Quinolones are antibiotics. Quinolins are antimalarials. Folic acid antagonists, like I said, they block the folic acid biosynthetic pathway, or inhibitors of protein synthesis. So some other specific ones are listed here. We'll talk about particular antiprotozoals as we talk about the different protozoal agents. But if you refer to the table in your text, table 71-2, that has even more information about some of these antiprotozoal drugs. For helminths are even harder to treat. These are our multicellular worms, basically. Oftentimes, it's hard to get rid of the larval stage, so you target the adult instead. Some of the drugs are listed here. One that's kind of interesting is this class of drugs listed at the bottom. I'm not even going to try to pronounce that, but they help make the worm more accessible to antibodies. So if you've taken immunology, or if you're taking immunology, You might have talked about IgE and how IgE is this antibody that's actually, we tend to think of it as being more associated with an allergy response. It causes an allergic reaction. But IgE is also the antibody that is supposed to target parasites. And sometimes parasites have a coat around them, it's called a tegument, that can make it difficult for antibodies to bind. And so some of these drugs down here, like at the bottom, can actually make the tegument more accessible to antibodies. And so that's what we're showing in this cartoon. Prior to treatment with the drug, the antibodies can't really bind to the surface of the tegument, but once they've been exposed to the drug, you expose these, more bumpy features that allow the antibodies to bind, recruit immune cells, and end up leading to death of the parasite. So again, we'll talk more about the various antiparasitic agents as we talk about the various parasites, but it is really important that you think about the challenges in treating all of the different types of infections that we've talked about throughout the semester.